তা আজকে যেটা আমরা লেকচারটা আমরা শুনবো সেটা থার্ড লেকচার, যেটা সিরিজ আমাদের হয়েছে আগে। যে প্রথমটা হয়েছিল আমাদের অ্যাকিউট ডিকম্পেনসেটেড হার্ট ফেলের উপরে, যেখানে আমরা দেখেছি যে পেশেন্ট গুলো যারা এমার্জেন্সি রুমে আসে অ্যাকিউট ডিকম্পেনসেটেড হার্ট ফেলিয়ার, তাদের ম্যানেজমেন্টটা কিভাবে হয়। দ্য সেকেন্ড সিরিজ লেকচার যেটা আমরা দিয়েছি সেটা হলো হার্ট ফেলিয়ার ম্যানেজমেন্ট উইথ রিডিউসড এলভি সিস্টোলিক ফাংশন, যেটা ক্রনিক সিস্টোলিক হার্ট ফেলিয়ার বলি, এবং সেটার কিভাবে আমাদের ম্যানেজমেন্টের যে এভলিউশন এবং আমাদের থিঙ্কিং প্রসেস চেঞ্জ হয়েছে, বিভিন্ন হাইপোথিসিস এসছে, এবং ডিপেন্ডিং অন দ্য ডেটা দ্যাট উই হ্যাড, এভিডেন্স বেসড মেডিসিন, আমাদের বিভিন্ন যে হাইপোথিসিস একসঙ্গে করে যে আমরা যে চিন্তা ভাবনা করেছি, যে আলটিমেটলি আমরা একটা গাইডলাইন ডিরেক্টেড মেডিকেল থেরাপিতে অ্যাপ্রোচ করেছি, যেটা হিউজ ইম্প্যাক্ট করেছে পেশেন্টস মর্টালিটি অ্যান্ড ওয়েলবিং এ। কিন্তু আজকে যে থার্ড টপিকটা আমরা বলবো সেটা হলো হার্ট ফেলিয়ার উইথ প্রিজার্ভড ইজেকশন ফ্র্যাকশন। হ্যাঁ, এটা একটু কনসেপ্টটা একটু ডিফিকাল্ট টু আন্ডারস্ট্যান্ড, কারণ আমরা অনেক বছর ধরে দেখেছি যে আমরা এটা রেকগনাইজ করিনি। হ্যাঁ, আমরা হয়তো বুঝতেও পারিনি যে 15-20 বছর আগে আমাদের আইডিয়াটা তখনো ফর্মুলেট করেনি এইভাবে, যে এইটা আবার কি ধরনের এন্টিটি, যদি ইনজেকশন ফ্র্যাকশন নর্মাল থাকে, হ্যাঁ, এবং বিএনপি যদি নর্মাল থাকে, কি করে এটা হার্ট ফেলিয়ার ডেফিনেশন দেওয়া যায়। বাট আনফর্চুনেটলি মিসড লট অফ পেশেন্টস। হ্যাঁ, কারণ জিনিসটা হলো কি, যেটা আমরা দেখছি যে হার্ট ফেলিয়ার উইথ প্রিজার্ভড এলভি সিস্টোলিক ফাংশন, তাদের যে mortality rate, they're pretty much similar as mortality rate with reduced ejection fraction. এবং শুধু mortality rate না, আপনার quality of life, হ্যাঁ, they are similarly reduced as compared to heart failure with reduced ejection fraction. So এই বেসিক আন্ডারস্ট্যান্ডিং এ যেটা আমরা আজকে আলোচনা করব, সেটা আমরা দেখব যে কিভাবে আমরা এই উপলব্ধিতে এসেছি যে এই ডায়াগনোসিসটা আমরা অনেক সময় মিস করেছি। হ্যাঁ, দ্যাটস দ্য ফান্ডামেন্টাল ইম্পর্টেন্ট ইনফরমেশন আই নিড টু গিভ ইউ। কারণ এটা একটা কমপ্লেক্স কনসেপ্ট। প্লিজ আমাকে ইন্টারাপ্ট করেন, কোনো যদি বুঝতে অসুবিধা হয় আমাকে প্রশ্ন করুন, আমরা একটা ইন্টারেক্টিভ সেশন করব। সো আজকে যেটা আমাদের লার্নিং অবজেক্টিভ সেটা হলো যে হার্ট ফেলিয়ার উইথ প্রিজার্ভড ইজেকশন ফ্র্যাকশন, এটা ডেফিনিশনটা কি, হ্যাঁ, এটার এপিডেমিওলজি এবং ডায়াগনোসিসটা আমরা কিভাবে করব, এটার মেইন প্যাথোফিজিওলজিক্যাল ড্রাইভিং ফোর্সটা কি যেটা ডেভেলপ করে হার্ট ফেলিয়ার উইথ প্রিজার্ভড ইজেকশন ফ্র্যাকশন, এবং ডেফিনেটলি আমরা কি পর্যায়ে এসেছি এবং কিভাবে আমরা ম্যানেজ করতে পারবো। জানিয়ে রাখি যে আমাদের ম্যানেজমেন্টটা এখনো লিমিটেড। আমরা প্রথমে আমরা দেখি যে আমরা আগে এটা দেখেছি যে ক্লাসিফিকেশন অফ হার্ট ফেলিয়ার, হ্যাঁ, যে আমরা জানি যে রিডিউসড ইজেকশন ফ্র্যাকশন, আমরা বলি যে ইজেকশন ফ্র্যাকশন যদি 40% অর লেস থাকে তাহলে এটা স্ট্যান্ডার্ড, আমরা ওইভাবে ডিফাইন করি হার্ট ফেলিয়ার উইথ রিডিউসড ইজেকশন ফ্র্যাকশন। কিন্তু কোনো পেশেন্টের যদি রিডিউসড ইজেকশন ফ্র্যাকশন থাকে বিলো 40%, কিন্তু আমরা ট্রিটমেন্ট দিয়েছি, তার হার্ট ফেলিয়ার ইমপ্রুভ করেছে, হ্যাঁ, তখন সেটাকে আমরা বলি এখন ইমপ্রুভড ইএফ, হার্ট ফেলিয়ার উইথ ইমপ্রুভড ইএফ। আমরা কিন্তু বলছি না, কারণ ওই টার্মিনোলজিটা আমরা এখন ইউজ করি না, যে নর্মালাইজেশন অফ দ্য ইজেকশন ফ্র্যাকশন, কারণ এটার ইমপ্লিকেশন আছে। হ্যাঁ, কারণ আপনি যখন একটা পেশেন্টকে বলেন যে তার হার্ট উইক ছিল এখন নর্মাল হয়ে গেছে, পেশেন্ট মনে করতে পারে ও আই এম ফাইন, আই মাইট হ্যাভ টু স্টপ দ্য মেডিকেশনস, হ্যাঁ, আমার মেডিকেশন দরকার নেই। এই মিসকনসেপশনটা দূর করার জন্য আমরা নতুন টার্মিনোলজি ইউজ করছি, হার্ট ফেলিয়ার উইথ ইমপ্রুভড ইজেকশন ফ্র্যাকশন। হ্যাঁ, যাদের আগে 40% অর লেস ছিল কিন্তু ইমপ্রুভ করেছে অ্যাবভ দ্যাট। তারপরে মিড রেঞ্জ ইজেকশন ফ্র্যাকশন যেটা বলা হয়, কারণ আমাদের মোস্ট অফ দ্য স্টাডি ওয়াজ ডান উইথ রিডিউসড ইজেকশন ফ্র্যাকশন বিলো 40% অর বিলো। হ্যাঁ, আর আমরা আগে আমাদের ডেফিনেশনে আমরা ধরে নিয়েছি যে 50% অর অ্যাবভ ইজ নর্মাল ইজেকশন ফ্র্যাকশন। হ্যাঁ, কিন্তু এই যে মিড রেঞ্জে যে আছে 41 থেকে 49%, এটাকে আমরা ডিফাইন করি এখন হার্ট ফেলিয়ার উইথ মাইল্ডলি রিডিউসড ইজেকশন ফ্র্যাকশন, মাইল্ডলি রিডিউসড হার্ট ফেলিয়ার এমআরইএফ, হ্যাঁ, মাইল্ডলি রিডিউসড ইজেকশন ফ্র্যাকশন। ডেফিনেটলি থার্ড যে পরের যে গ্রুপটা আসছে, ফোর্থ গ্রুপ, সেটা হলো হার্ট ফেল উইথ প্রিজার্ভড ইজেকশন ফ্র্যাকশন, হ্যাঁ, যেটা নতুন ডেফিনেশনে আসছে। সেটা হলো ejection fraction 50% or above, and they definitely have symptoms of heart failure. কিন্তু মেইন কম্পোনেন্ট যেটা হেফ রেফ যেটা বলি, হার্ট ফেল উইথ প্রিজার্ভ ইজেকশন ফ্র্যাকশন, আমি হয়তো ইউজ করবো হেফ রেফ এই শব্দটা। এটা হলো কি, যে তাদের ফিলিং প্রেশার ইজ হাই ইন দ্য ভেন্ট্রিকল। সেটা আমি পরে একটু ডিটেল এক্সপ্লানেশনে যাব। তো এই ফিলিং প্রেশারটা এটা ক্লিনিক্যালি আপনি ডিফাইন করবেন অথবা ইনস্ট্রুমেন্টালি ডিফাইন করবেন, হ্যাঁ। এবং তাদের বিএনপি অথবা এনটি প্রো বিএনপি মে অর মে নট বি এলিভেটেড, হ্যাঁ। কিন্তু যদি থাকে এলিভেটেড, ডেফিনেটলি ইউ আর মোর কনফার্ম উইথ দ্যাট, হ্যাঁ। কিন্তু এইটা হলো কি 50% above or clinical evidence of elevated filling pressure or BNP elevation, either elevated filling pressure you can define with non-invasive testing like echocardiogram or other testing, non-invasive, or you can define with invasive testing with right heart catheterization. এটা ইম্পর্টেন্ট কেন? আমরা যদি দেখি যে হার্ট ফেলিয়ার যে এভলিউশনটা, হ্যাঁ, যে আমরা মোর ফ্যামিলিয়ার উইথ রিডিউসড ইজেকশন ফ্র্যাকশন, যেটা এই লাইনটা উইথ রিডিউসড ইজেকশন ফ্র্যাকশন, আমরা যদি দেখি যে আমাদের যেহেতু সিগনিফিক্যান্ট ইমপ্রুভমেন্ট ইন ট্রিটমেন্ট হয়েছে রিডিউস ইজেকশন ফ্র্যাকশনে, আমরা কিন্তু ওদের প্রিভ্যালেন্সটা কমিয়ে আনতে পারছি technically. Okay, with the treatment they improve their quality of life, doing better, the mortality is being reduced, so it's getting trending downhill a little bit, and then plateaus so far. Okay, কিন্তু heart failure with preserved ejection fraction আগে আমরা একটা ডায়াগনোসই করতে পারিনি। 15-20 বছর আগে আমরা এটা নিয়ে চিন্তাও করিনি, আমরা ধরি নাই যে এটা হার্ট ফেলিয়ার, হ্যাঁ। সেই ডিটেলস আমি পরে আসছি। কিন্তু দেখুন কার্ভটা কি, দে ক্রসড ইট and they actually becomes more prevalent right now. And interestingly enough, if you look all the heart failure population, more than 50% right now belong that group, more than 50% ejection fraction of above 50% in the preserved ejection fraction heart failure is all the heart failure population. They are more than 50%, and most commonly also in women that we miss it. Okay. এবং আমরা যদি মোর্টালিটি দেখি, দ্যাটস ইম্পর্টেন্ট পয়েন্ট, কারণ শুধু over the years we looked at the data, that they definitely তাদের mortality হচ্ছে either cardiovascular cause or non-cardiovascular cause. If you combine these two, half of them don't live above 5 years. Half of them. That's a huge mortality risk there. Cardiovascular death and non-cardiovascular, if you take it that 5 years, there's 25% of each. You combine them is 50%. So half of them will not live beyond 5 years. There's significant mortality rate in that population. Okay. তারপর আরেকটা important data, not only mortality, their quality of life. They're over the time they get very dysfunctional. They're very short of breath. They cannot go to the bathroom. They cannot go to the mailbox. Even minor walking, they are short of breath. Their quality of life significantly decreases. And আমরা যদি দেখি যে মেজর ডেটা যেটা আসছে, যে কোয়ালিটি অফ লাইফ ডেটাটা, যে প্যারাডাইম ট্রায়াল, যেটা আর্নি ট্রায়াল উইথ রিডিউস ইজেকশন ফ্র্যাকশন, এবং ওয়ান অফ দ্য লার্জেস্ট ট্রায়াল অফ দ্য হার্ট ফেলিয়ার উইথ প্রিজার্ভড ইজেকশন ফ্র্যাকশন, সেটা প্যারাগন ট্রায়াল, হ্যাঁ। এবং এখানে আমরা দেখেছি যে এখানে কোয়েশ্চেনার করা হয়েছে, যেটা ক্যান্সার সিটি কার্ডিওভাস্কুলার কোয়েশ্চেনারে দিয়ে ওরা কোয়ালিটি অফ লাইফ ডিফাইন করেছে, এবং দেখতে পাচ্ছি যে রিডিউস ইজেকশন ফ্র্যাকশন and heart failure with preserved ejection fraction, their decrease in quality of life is about the same. Both are the same. So heart failure preserved ejection fraction যদি হয় এবং reduced ejection fraction of the heart, both of them have poor quality of life. যদি আমরা হার্ট ফেলিয়ার ইজেকশন ফ্র্যাকশনটা দেখি যে তারা কিভাবে প্রোগ্রেস করে, তাই না? যদি আমরা মোটামুটি দেখতে পাচ্ছি যে এটা একটা ডেটা এসছে ইটালিয়ান কোহর্ট থেকে আর কি, এটা 10 years, more than 10 years ডেটা। হার্ট ফেলিয়ার প্রিজার্ভ ইজেকশন ফ্র্যাকশন, তাদের ইএফ কিন্তু মোটামুটি মেইনটেইন করে ওভার টাইম, দে ডোন্ট ফল অ্যাব্রাপ্টলি। If they do fall, if the ejection fraction falls, there should be some other reason, or there is a cardiac ischemic reason, myocardial injury, or certain other reasons on top of that what they had before. So most commonly they might have preserved ejection fraction for a long time, but they have progressive worsening of the cardiac output, and progressive worsening of the clinical symptoms and mortality rate is high. So that's very interesting findings that we have from this cohort study. And looking at the data that we have on all the trials that we had last 30, 40 years, we have trial with ACE inhibitor, SOLVE trial with ACE inhibitor, CVS trial with beta blocker, MADE trial with long-acting metoprolol like toprol-XL, CHARM trial with valsartan, Emphasis trial with ARB, Paradigm trial that we talked about, ARNI, Entresto, MEDI2 trial with ICD, SCOT-HAP trial with ICD, CRT trials, the Copernicus, the carvedilol trial, spironolactone যেটা MRA trials, তারপরে even if you look at the device therapy এবং left ventricular assist device therapy, all have proven benefits in mortality in the group with reduced ejection fraction, like LVEF of less than 40%. So you have enough data. Trials after trials have shown that if we can target the neurohormonal axis and anti-inflammatory axis, we can definitely benefit in all those trials. Most commonly, we do see the benefit in reduced ejection fraction. So what happened with heart failure with preserved ejection fraction? Not that they did not do those studies, the same medication they tried with patients with heart failure with preserved ejection fraction. Do you have any much data on that? And interestingly enough, until 2014, it was totally blank. Not a single study showed any proven benefit in reducing mortality in this group of heart failure with preserved ejection fraction until 2014. So that's a huge issue, because we could not really had something in our arsenal to improve their survival and quality of life. So let's have a case here. You can prepare a form for that. A very quick case to understand it where you are. A 65-year-old female with a history of hypertension, persistent atrial fibrillation, obesity, stage 3 kidney disease. It presented this time progressive short of breath. And that's the most common symptoms, like become a short of breath and leg edema. Blood pressure is acceptable, slightly high, lungs clear. There's some elevated JVT, mildly elevated. There's some edema there bilaterally, and definitely body mass index is 41, elevated. Patient has been on losartan, ARB, amlodipine, furosemide, metoprolol, has been on blood thinner, Eliquis for stroke prevention for AFib, MRA, 12.5, spironolactone. And you do an echocardiogram. That's most commonly you do an ultrasound of the heart when the patient comes with short of breath and leg edema. You need to define how much is heart related or not. Okay, so you do that, and your pumping function is 55%. There's moderate concentric LVH, mild tricuspid regurgitation, and mild pulmonary hypertension. PS systolic pressure is 38 millimeter mercury. Just have a poll here. What is the likelihood, pretest probability with that information that you have, the patient has heart failure with preserved ejection fraction? What's the percentage, do you think? I'll just like to get a poll to understand. Let's have a poll on that.
এক নাম্বার ফর্মটা দাও।
সো আমি আবার দিচ্ছি যে এই হলো তার ক্লিনিক্যাল সিনারিও। হ্যাঁ, হাইপারটেনশন আছে, এফিব আছে, ওবিসিটি আছে, স্টেজ 3 কিডনি ডিজিজ আছে, এবং definitely patients came with volume overload and ejection fraction normal, moderate concentric LVH, mild pulmonary hypertension. Just 30 seconds, just pick a number. I'm not expecting you to be accurate. I just wanted to see where you are, because it is very important to keep an eye on those patients, because very often we'll miss those patients, and these patients will move around from doctor to doctors. They'll go to the pulmonary doctor, they for any pulmonary cause, they come back to the cardiologist, they go back to different doctors. So they're shopping doctor to doctors because they are not getting benefit.
ওকে, ফর্মটা দেওয়া আছে, একটু ক্লিক করে আপনারা অপশন সাবমিট করেন, এ বি সি ডি ই, যেটা মনে করেন আপনারা। ওকে, আমি একটু আনসার জানাই আপনারা কে কি সাবমিট করছেন।
Give me the most common answer, যে সবচেয়ে বেশি কারা দিয়েছে কোন নাম্বারটা?
জি স্যার।
আমি ফর্ম দিয়েছি, ফর্মটা পূরণ করতে পারেন এখানে আনসার না করে।
একটু ফর্মে পূরণ করেন, হ্যাঁ
হ্যাঁ,
ফর্ম
চ্যাট
পূরণ করে
বক্স কিন্তু
সাবমিট
আমরা এখন দেখছি না। হ্যাঁ,
স্যার সি পাচ্ছি, সি আর ডির মাঝখানেই বেশি আছে আর কি।
okay, that's not bad. Okay, so reason I put this slide here, don't miss these patients. Okay, and I think C and D definitely
মেজরিটি মানে
patients.
50-50 আর কি।
Yeah, so you will have the answer in between these two, and I'm going to show you the results later on. And let's go through that, why that high prevalence of that, high pretest likelihood the patient might have heart failure with preserved ejection fraction. Okay. So when you look at that definition of heart failure, there's an universal definition, you know that. There's a signs and symptoms of heart failure that should be caused by either structural and functional cardiac abnormality. That's our standard definition. Okay, and definitely you can supplement that with the patient has elevated BNP level or NT-proBNP level, and definite or objective evidence of cardiopulmonary or systemic congestion, like elevated JVD, lung crackles, or lower extremity edema. That's we define as universal definition. There's a difference in heart failure with preserved ejection fraction. Okay, but when you look at the BNP level, what are the normal numbers that you need to look at? Okay, or abnormal numbers in the ambulatory setting and hospitalized patient setting, we look at different numbers. Just you can take a picture of that. Make sure when you write down and you look at those numbers. If the ambulatory settings, BNP level is above 35 and or NT-proBNP level is above 125, equal or above 25. That's the ambulatory setting. In a hospitalized setting, when the patient gets hospitalized, their BNP level we accept as above 100 is a heart failure indication, or NT-proBNP level is above 300. But not necessarily that elevated BNP is always to the heart failure, because there are some other reasons for elevated BNP level, like kidney failure or other reasons, but we'll talk about later on. But definitely those BNP levels, that's our standard, that we need to look at that in normal heart failure definition. But in heart failure with preserved ejection fraction, mind it that BNP level are not that high. They are in the lower range. That might confuse you, okay? We know that in patients with obesity, their BNP level generally on the low side. So these two things you need to remember that. So if you rely on BNP level or NT-proBNP level, you might be missing a lot of patients with heart failure with preserved ejection fraction. And একটু আইডিয়া দিই যে কেন হচ্ছে বিএনপিটা আমাদের রিলিজ হচ্ছে because of the stressing of the wall stress on the myocardium is high. When it's higher wall stress, you release more BNP or NT-proBNP, right? So if you look at that, this is a dilated cardiomyopathy, right? So wall stress is defined by what's the pressure in the left ventricle and the radius from center to the wall, okay? If the radius is higher, so that's the formula, right? LV pressure multiplied by radius divided by wall thickness. So in dilated cardiomyopathy, wall thick is very minimal, so it's on the bottom. Radius is longer, and pressure, imagine pressure is the same. Okay, so in between these two, wall stress is much higher here simply by this formula, right? Look at that, wall thickness is high. Normally people with preserved ejection fraction, most commonly they have hypertension. They might have a thickened wall. When the thickened wall, it goes to the bottom, then it definitely reduce, by the formula, wall stress becomes less. So these type of patients may have less BNP release. So this just to have an idea why these patients might have less BNP release despite that they're in heart failure, okay? So now let's have another clue, okay? What percentage of patients with preserved ejection fraction heart failure patients will have normal BNP or NT-proBNP? Because reason is very important to look into that, keep in mind, as I mentioned earlier. So let's have a poll. How many percentage do you think that they might have? Okay.
Next ফর্মটা দাও। ফর্মটা দিলে সবাই একটু সাবমিট করবেন প্লিজ।
হ্যাঁ, প্লিজ সাবমিট করেন। Just put any number. I'd like to see where you are. আমি এটা awareness-টা বাড়াতে চাচ্ছি। It's not merely a question, but awareness that you need to look for what you not rely on the pro-BNP all the time in heart failure with preserved ejection fraction. They will have elevated pro-BNP or elevated BNP, but not all the time. Okay.
এখানে আনসার করার দরকার নেই, আমরা একটু চ্যাট বক্সে আপনাদেরকে সুযোগ দিব। আমি ফর্মটা দিতেছি একটু, আপনারা
just to have an idea.
একটু ফর্মটা সাবমিট করেন। I think 30 seconds is enough. যেটা মনে হয় ABCD আপনারা জাস্ট একটু করেন।
যা খুশি।
এখানে তো স্যার ডি ডি বি বি সি সি বি সি বি বি ডি BCD এর মধ্যে ঘুরতেছে স্যার।
Basically, let me help you with that. Ideally, all the data we have is about 30%. Okay, the right diagnosis is weak, and sometimes the internal medicine board question tashe. So about 30%. The reason why it's important to understand that, কারণ অনেক সময় ধরুন এই পেশেন্টটা আসছে আপনার শর্টনেস অফ ব্রেথ, লোয়ার এক্সট্রিমিটি এডিমা, দিস টাইপ অফ সিম্পটমস নিয়ে আসছে ইসে আর কি হসপিটালে emergency room আপনি BNP করলেন অথবা NT-proBNP করলেন, it's not high, it's within normal range. Can you refute, deny that the patient does not have heart failure? No. The reason is only 30% of this heart failure with preserved ejection fraction will have elevated BNP, only 30%. So they might not have it. That doesn't mean you cannot exclude the diagnosis of heart failure in these patients. So bottom line, yes, if you're relying on pro-BNP alone, it might mislead you in heart failure with preserved ejection fraction. এখন আমরা দেখি যে heart failure with preserved ejection fraction current definition-টা আমরা কিভাবে করছি। Definitely the patient should have signs and symptoms of heart failure. Second most important, they have LVEF above 50%, 50 or above, okay? এবং ইন্টারেস্টিং পয়েন্ট এটা যে যদিও ওই পেশেন্টের আগে low ejection fraction থাকে below 50%, they will not qualify for the HFpEF. কারণ আগে যদি low ejection fraction ছিল ধরুন 40%, তার এখন 55% হয়েছে, they will qualify for with the heart failure with improved ejection fraction. They actually began with low ejection fraction. With heart failure treatment, they improved. So that's also another criteria, no prior EF less than 50%. কারণ অনেক সময় ক্লু থাকতে পারে যে ইনজেকশন ফ্র্যাকশন 34% ছিল, এখন 55%, ওই পেশেন্ট এখন HFpEF আছে কিনা, they will not qualify for that. তারপর definitely need to make sure they don't have any severe valvular heart disease, okay? তারপরে কি, and objective evidence of elevated filling pressure, that's the key point. কারণ হচ্ছে কি, left ventricular end diastolic pressure is elevated on that patient, and that elevation goes to the left atrial. The left atrial pressure eventually goes higher, and that, since our circulation is a loop, is a circuit, closed circuit, that pressure, left atrial pressure, goes to the lungs, and they get short of breath. That's the major symptoms. That's the main problem in these type of patients. The filling pressure is higher than normal patients. So elevated evidence of elevated left ventricular filling pressure, that's the most important thing you need to look at. And if you do either at rest they're elevated, or with exercise. Because some patients might do well at rest. When they walk a little bit, go uphill like একটা সিঁড়ি বেয়ে বা 2 সিঁড়ি বেয়ে উঠলো দোতলায়, হাঁপিয়ে যাচ্ছে। হ্যাঁ? So that's the objective evidence. How you can define that? You can measure the pulmonary capillary wedge pressure either by right heart cath or simply put a Swan-Gonch catheter through the jugular vein. You can measure it in the cath lab setting or the ICU setting, or even the emergency room setting. You can do that. এবং simply যদি slight exercise করানো হয় ওদের supine position-এ, if the pulmonary capillary wedge pressure goes 25 above, then you have the diagnosis, confirming diagnosis, okay? Because then you can relate that his symptoms is very well connected with the elevated filling pressure in the ventricle. যদি left heart catheterization করেন, definitely measure the LVEDP. That will be a measure of the same thing, pulmonary capillary wedge pressure. That's we do on the right side by occluding the pulmonary arteriole, pulmonary artery. But LVEDP on the left side, you can measure the end-diastolic pressure. This is exactly similar measurement. Okay, diastolic stress test. Okay, so you can do some sort of testing with the echocardiogram with exercise, or you can do in the cath lab. You can do some volume channel, give 500 cc of volume, saline, and you see that their wedge pressure goes way up, very steep rise, okay? Definitely if they have BNP or pro-BNP level, they may not have 30%, they don't have, but if they have, that will help you, okay? So that's the criteria for heart failure with preserved ejection fraction. And we know the signs and symptoms of heart failure. We already went through that. They have to have short of breath, orthopnea, PND, edema, weight gain with fluid overload, elevated jugular venous pulse, pulmonary venous congestion on chest X-ray, crackles on auscultation, S3 sound, hepatomegaly. Those are the signs and symptoms of heart failure. Okay. So let's look at another case. Okay, a 65-year-old female with a history of hypertension, obesity, presented to you with dyspnea on exertion, মানে shortness of breath নিয়ে এসছে, এবং lower extremity edema. Blood pressure is borderline. BMI is 35, so she's obese, and no significant. Actually, jugular venous distension. Our resident wrote down NAD. Okay, I mean, we a lot of time they don't look at the JVD. Okay, they said not actually done. Okay, but it's nothing abnormal detected. That's the way we do that. Use that abbreviation, but it could be also used as not actually done. But most of the time they don't do it. Okay, so you need to learn how to really look at the JVD. No wheezing, no rails. There's two plus peripheral edema. Okay, but ejection fraction is normal. Okay, borderline LVH, no significant valvular disease, grade 1 diastolic dysfunction. I'll talk about that. And pulmonary, and patient went back and forth with a short of breath with different doctors. He also saw a pulmonary doctor. Pulmonary function test is normal within range, and pro-BNP is only 28. That's within normals. But this is the patient scenario. Okay, so does this patient have a HFpEF? Okay. There's a likelihood the patient has. I'm not going to go there, because the reason I'm putting this slide, that he has all this shortness of breath, lungs clear, no valvular disease, and no pulmonary disease, no valvular disease, but he does have symptoms of short of breath with exertion. Okay, you cannot rule it out. The reason you need to think about yes, because in your mind you need to further investigate the patient, further need to define the patient, whether the patient is HFpEF or not. Because otherwise this patient will go back and forth. There's a good chance that in 5 years, the patient will probably not survive if you don't do anything for him. Okay. So how we work up on these patients? Definitely short of breath. That's the main problem, right? Dyspnea. So you need to rule out, when the patient comes to you need to rule out whether the patient has true cardiac cause or pulmonary cause or other cause, right? And shortness of breath could be, if the patient is anemic, can have shortness of breath. Neuromuscular disease can have short of breath. Patient is physical decondition, they can have short of breath. Anxiety, they can short of breath. These are the other variety of sources. Okay, but definitely need to exclude these and also exclude the pulmonary causes. Okay, so I'm going to this direction, then you can come back to cardiac cardiac direction, okay? So you need to rule out whether the patient has COPD, asthma, those type of obstructive lung disease, whether the patient has restrictive lung disease, okay? You can do a pulmonary function test and see the DLCO, okay? If it is low, then you know it's a diffusion problem, restrictive lung disease. Or restrictive lung disease, I'm talking about that because neuromuscular problem, the lung is not expanding. It's a lot of reasons could be. Pleural disease, there's some that could be also can cause short of breath. Pulmonary embolism definitely can cause short of breath. If you rule out all those, then you look at that, whether there's any cardiac reason, okay? If the patient has cardiomyopathy, whether the patient has coronary artery disease, valvular heart disease, okay? Pericardial disease, arrhythmia, like rapid AFib or tachyarrhythmias. Definitely, you look at those things and try to start formulating differential diagnosis on these patients, okay? And the second component that patients come with, not only short of breath, most commonly they come with edema, right? You need to really look at that. What are the other sources of edema that you need to rule out? Because in order to diagnose the patient's HFpEF, you need to rule out other causes first. Then you come to that conclusion, the patient has a HFpEF, okay? And we know that edema, there's two major reasons, really low oncotic pressure, capillary oncotic pressure, or high hydrostatic pressure, capillary pressure. The oncotic pressure, that means they have low albumin, mostly in the bloodstream. Okay, this oncotic pressure is low. That could be related to low protein intake, protein production, like liver cirrhosis, malnutrition from the protein intake, protein loss. It could be from GI loss, malabsorption, or it could be nephrotic syndrome from the kidney loss. So you rule out that first. Then you go to hydrostatic pressure, increase hydrostatic, that group, okay? Rule out other causes first. Most commonly, patients have venous insufficiency, lymphedema, those type of things, very common. You need to rule it out. Pregnancy can do that. Different kind of medications, like as you know that amlodipine can cause that. About 9-10% of patients, they will have swelling in their legs. And non-steroidal anti-inflammatory medications, steroids can cause swelling. So if you have those causes, you can attribute that the swelling due to that. But if you don't have, then go to other causes. Then we talked about renal cause, renal failure can do that. Cirrhosis with portal hypertension can do that. Then you look at the cardiac cause. Then slowly, you differentiate out those causes because you need to exclude those causes in order to come to the conclusion of heart failure with preserved ejection fraction. Okay, you can take pictures of that. Actually, you can find that in SEC Expert Consensus in Heart Failure with Preserved Ejection Fraction. It's a Jack big article, 2023. But you can also take a picture of that. And then you look at the cardiac cause, okay? If the patient has different type of cardiomyopathy, patient has valvular disease or pericardial cause. These are the major group. You need to look at that, okay? So you rule out some other causes first, and then you come back where the cardiac causes are there, then rule out the different kind of cardiomyopathy, like infiltrative, I'm coming to that. And when you rule out, then you can think about whether the patient has HFpEF or not, okay? So, it's definitive, patients come with swelling. If you see that, definitely lymphedema, okay? Very thick skin, inflamed skin, fibrosis there, and non-pitting edema, and chronic venous insufficiency, they will have pitting edema because you see the varicose type veins popping up. But definitely, if you see these causes, definitely swelling could be related to that. Then you might not go to HFpEF directly, okay? So there's a stepwise approach that you need to follow that I was just coming to that, okay? First, patients came to you with short of breath and edema, okay? First thing you do, definitely do some routine lab ECG because they can tell you a lot. If you do the ECG, if you see low voltage on the patients, okay, and you do the echocardiogram, you see thickened heart muscle but low voltage. Always think about amyloidosis, okay? So few labs you need to do, and then you, like normal chemistry, you need to do, you definitely check the protein level, and also do an echocardiogram. That's the first thing you do when you evaluate the patient with short of breath and edema, okay? And you found out the patient has ejection fraction above 50%, okay? Then you look at that. Second approach is going to be, what are the non-cardiac mimics of heart failure, okay? third approach would be what are the cardiac mimics of heart failure? You need to exclude both that I talked about on previous slides, okay? So non-cardiac we talked about, where there's kidney disease, liver disease, chronic venous insufficiency, anemia, different kind of things that we talked about on previous slides. You rule that out first. That is non-cardiac mimics, okay? Second, you come to cardiac mimics. That's very important because here are certain groups of patients you will find because they have more definitive treatment, okay? As for example, the patient has amyloidosis, they have definitive treatment available. The patient has sarcoidosis, they have definitive treatment available because it can improve their survival and quality of life if you diagnose properly in the right time, okay? And if it's hypertrophic cardiomyopathy, they have different definitive treatment available, okay? If pericardial disease, yes, there are some definitive treatment available. Even surgical option is also available, okay? Valvular heart disease, definitely you can, replace the valve or do transcatheter intervention. High output failure, and look at that, some other causes. So what could cause that? So these are different group of patients that we call heart failure mimics, but there's a cardiac mimics, okay? Initially rule out non-cardiac mimics that we talked about, then you rule out cardiac mimics. And because you know that if it's amyloidosis, now there's a treatment available with tafamidis, right? A significant improvement in quality of life and hospitalization, and a little bit of survival benefit was seen. And ATTR, transerythrin, the amyloidosis, they have definite treatment for that. তারপরে যদি আমরা hypertrophic cardiomyopathy in the medical treatment available, that's mavacamten, the inhibitor of the muscle filament যেটা আমরা বলি, তখন হবে কি with a definitive treatment available, অথবা you can do even surgical approach if there's LVOT in the asymmetric septal hypertrophy. So those or alcohol ablation, there's different treatment available for hypertrophic cardiomyopathy. So you should not miss those things in these patients, because if amyloidosis, if you don't treat them, their mortality rate is very high, okay? So after you ruled out initially non-cardiac mimics and then cardiac mimics, then you can define, okay, there's a likelihood that the patient has heart failure with preserved ejection fraction, okay? So, and it is important right now, when you came to the conclusion the patient has heart failure with preserved ejection fraction, then as I mentioned to you, there's not much data right now how to treat that. There's a few, trials available. I'm going to discuss those things. But in this group of patients, you have to look at that, what the other comorbidities come into play in these patients. Most particularly, the patient has hypertension. Most commonly, the patients are obese. Most commonly, the patient has diabetes. A lot of people in this group of patients, because they have elevated filling pressure, their atrium gets bigger. They commonly have atrial fibrillation, obesity, and they might have underlying coronary artery disease and kidney failure. So you need to address those things to treat those patients. So when you come to that conclusion, you need to look at that, what are the associated causes are related to these particular patients with HFpEF? The reason being, we can define some phenotype of these patients. We call phenotypic classification of HFpEF patients, because most patients, as I mentioned, obese, hypertension, or AFib, or diabetes. So you can define that, this type of group patients, okay? So these are a step-by-step approach, how we define, and come to the conclusion of the diagnosis of HFpEF. So few things that you need to look at, okay? There's some clues that how you can, rule out that maybe it is not true HFpEF, there could be mimics of that. Okay, because if you see that they have heart failure symptoms, but not many conventional risk factors. Okay, and if the patient have heart failure symptoms, but they don't have hypertension, you start thinking about it may not be HFpEF, it could be amyloidosis or something going on, or sarcoidosis going on. Okay, because most commonly patient with HFpEF, they will have hypertension, obesity, this type of things. Okay, if the patients are younger, they're not like older age. Okay. If the patient's BNP is way up, it's way up, it may not be HFpEF, it could be just amyloidosis or sarcoidosis or certain other kind of infiltrative, cardiomyopathy. And as we always kind of reflexively, we treat that with heart failure medications. We start like ACE, ARB, and those type of like beta blocker guideline directed medical therapy. And you'll be surprised that you do that, even low dose, they don't tolerate, they become hypotensive. So when you see that, then you might think about maybe this patient does not have truly HFpEF, maybe has some like amyloidosis or some other condition. Okay, so these are the clues you need to look at. Each clue is important when you do differential diagnosis. Okay, if you see on the EKG, the patient has a significant first degree block or a high grade block. Okay, so you need to start thinking about maybe the patient has sarcoidosis. Okay, so those are the important clues. Then you need to look into that to define and come to the conclusion ultimately that we need to rule it out first. Heart failure mimics that we call it. Those are the mimics. These are the clues to find out the mimics. Okay, and also if you look at the echocardiogram, if these patients have more like right-sided chamber enlargement and atrial chamber enlargement. Okay, so these are the clues you need to look into that. So and you can look at that. I talked about the clues that cardiac amyloidosis, that when to suspect that. These are we call heart failure preserved ejection fraction mimics. They are not true HFpEF, they are mimics of that amyloidosis, because what they have like LV wall thickness is very thick and speckled myocardium on the echocardiogram. They might have tiny effusion, and most importantly, very simple way, you know that when patient has LVH, you expect that amplitude of the R wave will be higher in the EKG. If you see that amplitude is low volt amplitude, but LVH, significant LVH, think about cardiac amyloidosis. Okay, hypertrophic cardiomyopathy is a clinical diagnosis. You listen to the patient, you hear the heart murmur, systolic murmur, ask them to do Valsalva, it increases. Okay, so the diagnosis is there. And if there's some other, the clinical things you can do, echocardiogram, CMR, like cardiac MRI. But I'm not talking about those details studies. I'm talking about how to quickly differentiate those by clinical exam and whatever minimum, testing we can do in our availability that we have in your local facility. Okay, cardiac sarcoidosis, right? They might have pulmonary involvement, eye involvement, dermatologic involvement. Okay, and EKG, if you see high-grade block, heart block, and ventricular arrhythmia, you think about that. They might have sarcoidosis. Okay. And then FDG PET scan would be very diagnostic, or cardiac MRI could be diagnostic. Okay, hemochromatosis, right? There's also another cardiomyopathy. They cause that with very increased ferritin iron level. Okay, and simply blood test, you can do that genetically or somewhat dominant related, patients. Fabry's disease. Those are kind of very rare, but myocarditis, you can look at that recent like viral infection, even COVID or something, they increase troponin level. So look at that, those mimics. Pericardial disease, right? Definitely, if the patient had chest radiation for any other reasons, for breast cancer or for Hodgkin's lymphoma. You can look at the echocardiogram, look at the thickening of the pericardium. They might need a CT scan to see the calcification of the pericardium. So these are the mimics you need to rule out. Okay? And these are the clinical clues you can look into that. So after you ruled out the mimics, then you put those patients in risk stratification criteria. There's two models that you have, that you use right now, H2FpEF model, and another one in European countries, they use that one, HFpEF model, a scoring system. We call it a scoring system, okay? Because that will give you some idea what's the likelihood the patient has HFpEF, okay, without doing invasive study. First of all, if the patient is obese, right? Most commonly, this is a phenotype, like obese patients, a lot of female patients hypertension. So if they have body mass index above 30, they get 2 points, okay? And just hypertensive, okay, medications, okay, they get 1 point, at least 2 or more hypertensive medications. You count those points, okay? Fibrillation get 3 points if they have underlying atrial fibrillation or paroxysmal atrial fibrillation. Pulmonary hypertension, if the pulmonary systolic pressure is above 35, okay, by echocardiogram, you can just easily measure it. They get 1 point. If the patient is above 60, they get 1 point. And if you do like feeling pressure, you can measure by Doppler echocardiography. I can give you some slight information because I don't want to go to detail because it's for general physicians, but for cardiology fellows, you need to know that. Okay, I'll go a little bit on the next slides about that. But you count those points, and then if it is more than 6, the likelihood that the patient has HFpEF is 90% or above, more than 6. It's a highly likelihood, okay? And European scoring system, HFpEF score, you can take a picture of these slides, okay, and keep in your pocket, okay? They pretty much take those similar, comorbidities and findings on the echo, but they go a little bit more detail on the echo. They look at the functional and morphological characteristics of the echo, and definitely they look at also the BNP levels, okay? I'm going to not to go the details because it will be too much here, but if you're a cardiology fellow or planning to do cardiology, you need to definitely need to understand that. So, and they get, if you look at that, I summarized in this slide, these 2 scoring system, HFpEF scoring, HFpEF scoring, okay? As I talked about, these are the points, you count that, and HFpEF score, what they do, they look at the major criteria and minor criteria, okay? If the major criteria is present, you get 2 points. Okay, minor criteria, you get 1 point, okay? This is the septal velocity. Septal velocity জিনিসটা কি? আমরা যখন ডপলার করি ইকোকার্ডিওগ্রাম, আমরা যখন এপেক্স থেকে ডপলারটা সেন্ড করি হার্টের উপরের দিকে, তখন একটা mitral valve level, we can get the velocity we call E2A velocity. I'm going to come to that later on in a slide. আমরা আরো যেটা মেজার করি যে how quickly the septal annulus part, annulus of the myocardium, like septal and the lateral part, how quickly they are squeezing and relaxing. Mainly relaxing টা আমরা দেখি, হ্যাঁ? So এইখানে যেমন septal E prime যেটা বলি septal relaxation, okay? এটা যদি 7 centimeter per second এর নিচে থাকে, then it's a positive for relaxing problem of the heart. কারণ HFpEF is major problems there is relaxing problem of the heart. I'm going to go to detail a little bit to understand in a picture because you will not be able to comprehend that, general physicians. But idea behind, you take 2 points on each of them if they're present, and you take 1 point on the minor criteria, each of them if they're present. Here, they look at the left atrial volume, they do the left ventricular mass index, relative wall thickness index, the different criteria they do. And look at that, if the patient has 0 to 1, none of them, almost 0 to 1, highly unlikely they have a HFpEF. You can just don't go further, okay? And if the patient has like HFpEF score, like HFpEF score 6 or above, highly likelihood they have HFpEF, then you don't need to do further study, okay? But in between, if the HFpEF score is in between 2 to 5, our A scoring system, if it is in between 2 to 4, then we call intermediate probability. Only then, and these two patients definitely need to refer to cardiologist, okay? They need to do some, if you have availability of that, it's not difficult to do. If the patient can have just Swan-Gonch catheter, they do this type of testing, hemodynamic stress test, they can do in the lab, okay? You don't have to have a cath lab for that. But at Swan-Gonch catheter, patients can do some exercise in supine position like stationary bike or raise the leg. That will also be some situation diagnostic, okay? Then you do those hemodynamic stress tests to confirm that only in this intermediate probability group, okay? Because this group, you don't know whether you can put them here or put them here. If it is negative test, then they don't have HFpEF. It's a positive test here, then definitely they have HFpEF. That's the step-by-step approach in the diagnosis of heart failure with preserved ejection fraction. And as you see, why it's important, even the scoring system, look at that. If the patient has already documented HFpEF, their risk of death and hospitalization is very high, right? In 5 years period, okay? Even they have, intermediate score, but they're symptomatic. Look at that. It's not that benign thing, but if they confirm, risk of death is very high, Okay. And that is validated by the HFpEF score and the European scoring system. This is the European scoring system and the US scoring system, HFpEF and HFpEF. Both are similarly, they could validate that, yes, if you have documented HFpEF, your mortality rate is very high within 5-year period. So what is the main understanding of that? In HFpEF, the main problem, the heart cannot relax well, okay? They are non-compliant ventricle. If they're compliant, means squeezing is good. They have good squeezing power. Their pumping function is good, but it cannot relax. Because normally heart has to relax very quickly. And when it's stiff ventricle, when the ventricle is stiff, what happens? At certain level of preload, the volume in the ventricle, if you measure the pressure there, then there's a correlation, okay? So that's the volume, okay? That's the volume. Normal condition, the pressure very little rise, but they are goodly correlated, like here. But in HFpEF patients, ventricles are so stiff, they cannot relax well. Same amount of volume, their pressure, if you measure the pressure in the ventricle, it's very steep, slope is very high. And that pressure is the left ventricular end-diastolic pressure, right? It's very high, okay? The same amount of pressure, volume that they have, okay? And if you increase the volume, the pressure even go higher. So they cannot tolerate extra volume because their filling pressure is already high. And that pressure translates to the atrium, then it goes to the lungs, you're getting short of breath. Okay, that's the mechanism we call pressure-volume relationship in HFpEF patients. And it was nicely done in 2004, Dr. Giles' group in Mayo, because this is the time we clearly started understanding that heart failure with preserved ejection fraction, something different. That is not like reduced ejection fraction patients. That's a fundamental study they did. Just simply, they did 25 patients. They found, 49 patients, and they found out their data. That's still valid today. So how they do, I'm not sure that I need to go with that. Let's see. The main criteria with that, if you measure either by, Swan-Gonch catheter or catheter, you see that pulmonary capillary wedge pressure. That's a measure of left ventricular end-diastolic pressure, as you understand when you occlude the pulmonary artery, okay? So if it is resting pressure is more than 15 and the patient's ejection fraction is normal, so that's not due to reduced ejection fraction. That is due to elevated filling pressure. That's pretty much diagnostic. If the patient has more than 15 at resting, just put a Swan-Gonch catheter in the lab or in the ICU or in the emergency room. Sometimes you put central line. Similar way, you can put Swan-Gonch catheter. If it's more than 15, here you have diagnosis and ejection fraction is normal. Then you don't need to go further. Okay, and definitely if it is not there like 14, 13, 12, but you do exercise on a bike, a stationary bike, if it goes to above 25, here you have the diagnosis. These two criteria mainly you need, okay? And interestingly enough, sometimes when you bring to the cath lab, just simply, you don't have to do exercise, raise the leg, okay? Like that's a diagnostic protocol. Like as for example, if the patient has greater than 15 resting, you already have diagnosis. You don't need to do any further testing. But it is less than 15 pulmonary capillary wedge pressure. First, you just raise the leg. If it is above 19, you don't need any further. You don't need to exercise. Just raising the pressure leg, you're elevating the filling pressure. That's quite enough, okay? But if you don't do that, then you can exercise the patient. And if you exercise, pulmonary capillary wedge pressure gets 24 above, then you have the diagnosis. That's more invasive testing. And that is mainly reserved for a group of intermediate scoring that we talked about earlier, when you're not sure whether they have HFpEF or not. If there's 0 to 1 score, they don't have it. If there's 6 to above 6, they already have it. You don't need this testing. If they're in between, then you do this testing, okay? This is an example of that. As for example, like if the patients like go on bicycle, you see that V wave is getting larger, way larger, okay? Up to 23, okay? And like, as for example, the patient is exercising 9 minutes on the bike, you see that pulmonary capillary wedge pressure up to 27 and V waves up to even 50. So that's the way you do in the cath lab to definitely confirm that. Some few examples for understanding of patients, how our general physicians get the echocardiogram and how to understand the diastolic dysfunction thing. Okay, I'm going to be very brief, but at least give some preliminary idea to understand that, because details definitely is more reserved for the cardiology fellows. But look at that. We are putting the probe. This is upside down picture. That's a standard way they do it. But we put the probe at the apex of the heart, at the apex of the heart at the bottom, and we put the Doppler here, exactly here on the mitral valve tip. Okay, both tip here. We put the Doppler here. We call pulse wave. Okay, and we measure the inflow velocity. Okay, so if you look at that curve here at the LV gram, right? We talked about that curve before. Okay, this is the mitral valve closing, aortic valve opening. That's what we call isovolumic contraction. There's two valves are closed by this time. And when your ventricle reaches certain pressure, like above the aortic pressure, then it opens up. Okay, the ejection happens, and then relaxation starts, and the ventricular pressure goes down. When it goes down below the aortic pressure, then aortic valve closes, because all the valves, you know that it work according to the gradient, okay, pressure gradient, okay? There's no active process on the valve. According to the gradient, it opens and closes. So when the aortic valve closes, okay, and the mitral valve is still closed, so it starts relaxation going on. And this part, two valves are closed, we call isovolumic relaxation. And when the left ventricular pressure falls below the atrium, the mitral valve opens. Then the filling happens. So this part we call early diastolic filling, okay? That is the part is reflected in the E wave. That's the E wave, the first wave, because it's called early diastolic filling, E, okay? So this part is responsible for this E wave on the echocardiogram, okay? Then you have good filling. If there is a good compliant ventricle, most of the filling would be in this part. That's why the velocity is higher in normal condition, okay? Then it starts filling, diastasis, and then the atrial kick happens, atrial contraction happens. That's the atrial part. That's the A wave, okay? And, you know, normally the E wave is higher than the A wave, okay? That we call normal variant. And that with this pattern, we call it mitral inflow pattern, how the ventricle gets filled up in the part of diastole. First part, due to compliance of the ventricle, this isovolumic relaxation happens, mitral valve opens, gush of blood goes to the ventricle, okay? That's the U wave. And then, a little bit later on, when the diastasis happens, then the atrial kick comes at the end of diastole, That's the U wave. That's the normal variant, okay? Now, what happens in diastolic dysfunction? Very brief. I know most of them you're not cardiology students, but still to have some understanding for the general physicians, because you will give this type of report from the echocardiogram to understand that what's happening. Okay, what happens when the patients get relaxing problem of the heart? Heart is squeezing is good, but relaxing is a little bit delayed, few milliseconds delayed. Okay, when it happens, relaxation delayed. That means relaxation goes on, most of the part of the diastole, the deceleration time increases, most of the part goes on in diastole, take most of the part because of the relaxing problem. It takes more time. The slope gets longer. The slope gets longer. So when it does so, the ventricle after opening of the mitral valve, it doesn't feel that amount of blood that they used to feel in normal heart when the ventricle is very compliant. That's the U wave is less compared to that, less. You see that here in this picture, less. And what happens, then the atrial contraction happens. Most of the filling happens from the atrial contraction, okay? So that's why E wave is less and the A wave is higher there. If you see that, that's what we call grade 1 diastolic dysfunction. Grade 1 diastolic dysfunction. Okay, you see that? Compared to this one, this is down, A wave is bigger, because most of the filling happening due to the atrial contraction. Okay? Then, if the relaxation goes further down because of this diastolic dysfunction goes advanced, then we see what happens there. As we talked about that, main problem in HFpEF patients, their filling pressure goes up in the ventricle. Filling pressure goes up. and they tend to retain fluid, okay? When the filling pressure goes up, you see there's a normal filling pressure, okay? And there's a higher level of filling pressure. If you measure from here, if you put a straight line here, and filling pressure is much higher, okay? When the filling pressure is much higher, so what's happening? When the mitral valve opens, the ventricle, atrium is emptying, right? Not active, just opening of the mitral valve, the blood has to go to the ventricle. When the filling pressure is already high, not much blood, you know, they have to push the blood, because against that pressure. The filling pressure is high, but not that high at this level, grade 2 level, okay? But they have to push that pressure with high velocity, okay? Then you see there's a reversal of the E wave. You see the E wave is greater here, and the A wave is smaller. And it may look like normal, like look at that, this one compared to this one. It looks like normal, but it is not normal. It cannot be normal. If you have documented the patient had this type of feature before, now it is that unlikely that it is normal. We call it pseudo-normal or grade 2. And how to differentiate that? When you do ultrasound of the heart, we ask the patient to do Valsalva, like with closed mouth, have like going to potty, okay, and strain yourself. What it does, it decreases the inflow, mitral inflow, it decreases the volume, it decreases the preload. When it decreases the preload, then this patient immediately, when you put the probe, you'll see it reverses like that, immediately from here to here. Just putting the probe on the apex and ask them to do Valsalva, you'll see that will return to that. If you see that returning to that, it is grade 2 or pseudo-normal, okay? Pseudo-normal, okay? But also we do the velocity in the annulus. We check the velocity on the septal annulus, septal side, and lateral velocity, okay? We call tissue Doppler, we also do that. Not only in the middle of the mitral valve, we do tissue Doppler on the septal and lateral wall, okay? So when you do that, we know that if the relaxing problem is not good, is diminished, we know that the velocity will be lower, right? So you look at that this is the mitral septal annulus velocity, which is greater than 8. E prime means it is the annulus level, okay? E prime is greater than 8. And you see that this group is less than 8. So you know that relaxing problem is already there, despite that it looks normal. When you see that annulus velocity is less than 8 in the E prime, and you see that it looks normal, it has to be pseudo-normal. We call grade 2, okay? I know it's difficult to understand, but to give some idea, but I can explain you later on if you have questions, okay? Now, imagine it's progressing, okay? Filling pressure goes higher, left atrium gets bigger because that's the ultimate consequence of diastolic heart failure. Atrium gets way bigger, more volume, more pressure there, okay? So it happens to be that is severely increased left atrial pressure. Look at that here, compared to normal baseline, okay? It's higher, then even higher here, okay? So in that situation, when immediately in the early diastolic filling, the normal diastolic filling happened to be because the relaxing problem of the heart is so much, diminished, but the pressure is so high in the ventricle, okay? Left atrial pressure is so high that time because it's way high left atrial pressure, okay, way up. So when the left atrial pressure is way up, that's the left atrial pressure, and here left atrial pressure, here left atrial pressure. You see slowly increasing, okay? So that's the phenomena of progressing of the diastolic dysfunction, okay? So left atrial pressure is way up. So when the pressure is so high, when the mitral valve opens, it pushes gushes of blood because the pressure is too high, okay? It pushes the blood quickly because so high initial pressure. And that's how you see U wave is way tall. And then filling happens, okay, slowly. And then the atrium, when the atrial kick happens, pressure is so high in the ventricle, atrium is so big, it cannot push any blood much, okay? Very little contraction because pressure is high here and pressure is high here, not much difference at the end of the diastole. So atrial component is very minimal. So you see that very little A, it should be less than 25% of the E wave. When you see this pattern, it's very tiny A, that is a restrictive physiology. Restrictive, because patient diastolic dysfunction advanced so far, it went to restrictive cardiomyopathy. Okay, that's a bad, prognosis there. We call grade 3. There's another one, grade 4. In the restrictive physiology, if you do Valsalva, you just keep the probe there and ask the patient to do the Valsalva maneuver. You see this picture convert right away in front of your eyes like this picture. Because with Valsalva, you're decreasing the volume on the left side, left ventricular filling, and this picture can convert to that. If it does, then what's the clinical significance of that? That means it's still reversible. Still, you can treat these patients with diuretic. But with Valsalva, if it doesn't change at all, then it is stage 4 restrictive cardiomyopathy, very bad diastolic dysfunction. And this type of patients, how much you do diuresis, they're not going to improve, because you know that with Valsalva, it did not come back to that level. That means they have very poor prognosis. Still, they need diuretic, but not much improvement you expect. Because this type of patient, you know, to think about more palliative care or hospice care, or the patient's younger, you have facility to do heart transplantation, you need to recommend those patients for heart transplantation in grade 4. So these are the understanding, simple understanding. Remember these graphs, how they look like in different stages. But in the report for general physicians, you'll get grade 1 diastolic dysfunction, grade 2 diastolic dysfunction, or grade 3 diastolic dysfunction. Grade 3 is pretty bad, and grade 4 is way bad. Okay. So how the HFpEF patients, they progress? Definitely, initially they have just elevated pressure, but may not have much symptoms. But when they exercise, they would have symptoms. That's the initial phase, exercise-induced, left atrial pressure elevation. And then when it progresses further, they go resting left atrial hypertension, okay? And then ultimately, they get right heart failure, because that secondary hypertension goes to the right side, it affects the right side, and they get pulmonary hypertension and right heart failure. So this is the progression of the disease, and definitely we see the atrium gets huge and more right ventricular failure they have. And that's the comorbidity that basically the reason for the ultimate, outcome. Okay. So far, how we are going to treat these patients? Do we have enough evidence that any trial available that we could really change their course of life? So far, we knew only thing that we could treat is diuretics. Okay, we did not have any other medication that have proven in the past that could change the outcome of these patients. As I showed you in previous slides, that all the heart failure, trials that benefited extensively patients with reduced ejection fraction, but they did not benefit an outcome of the patients with preserved ejection fraction. Okay, but the HGL2 inhibitors, that's the only drug has proven benefit irrespective of the EF. And also this trial was especially done in patients with heart failure with preserved ejection fraction. There's a sodium glucose cotransporter 2, HGL2, that in empagliflozin or dapagliflozin that you use. It's a diabetic patients, diabetes medication, but it is the heart failure medications nowadays, okay? Either on reduced ejection fraction or preserved ejection fraction. We have seen that, definitely that this medication alone, definitely the proven benefit of that cardiovascular death and hospitalization for HFpEF patients, okay? Even the first hospitalization, they prevented that, they delayed that, okay? And definitely cardiovascular death. So that's the only drug that has a higher rank of recommendation and FDA approved for treating heart failure patients. Definitely they should be on diuretic, all patients, because that's the main problem. Volume overload in these patients, filling pressure is high. Diuretic should be on board, but definitely this medication also should be on board. And ARNI trials, what they have shown us, that's kind of ambiguous results we got, angiotensin neprilysin inhibition trial, jeta amra interesto, jeta ARNI amra use kori. Definitely it has proven significant benefit with reduced ejection fraction. There's no question on that. But they kind of fell short because they didn't have enough power to document that in the study. P-value is slightly short, but there was a definitive trend definitive trend, event rate for heart failure and death and cardiovascular causes, we see that compared to valsartan alone, ARNI definitely has some slight reduction in mortality. Okay, but they did not. They were not statistically significant, but it was statistically significant. This part, hospitalization, recurrent hospitalization, yeah, it has proven definite benefit there. So, and it was just short of, p-value was slightly short. So, but still is kind of 2B recommendation nowadays by American Heart Association and European Society of Cardiology guidelines. But interestingly enough, if you look at the sub-analysis of that trial, in the women benefited the most, and it was significant. The red group, women in HFpEF patients, they benefited the most. So you should still try these medications, okay? And both composite outcome, death and cardiovascular hospitalization and hospitalization alone. The women group benefited the most, okay? And also another group who had borderline EF, like EF in between 40 to 50%, okay? They benefited also, it was statistically significant on mortality. But it's above 50%, mortality was statistically not significant, but hospitalization was they benefited statistically, okay? But mind that group, don't miss that in women patients with HFpEF, you could use that. So another trial that happened in the TopCat trial, the MRA trial, it also missed the total outcome in the benefit of treating like cardiovascular death hospitalization. But interestingly enough, it was a multi-center trial and done in Europe, US, Canada, and Europe, and particularly in Eastern European countries. But this trial, when it was not a positive trial, mostly because some patients were enrolled in Eastern European countries, particularly Soviet Georgia at that time, included everybody who did not have actually HFpEF at all. Okay, like anybody came with pneumonia for other cause, anemia, but they had elevated BNP, they enrolled those patients. But if you exclude those patients, there is a good suggestion this medication is also helpful. So if you have option to try spironolactone, make sure they monitor the kidney function and potassium, you could use that. And we have seen in our practice that they do benefit in HFpEF patients with MRA. So what we have now, okay, we have now diuretic, definitely they have to be. That's the current treatment modality we can use in these type of patients. SGLT2 inhibitors on the top right now, okay, on the list. 2A is still. ARNI, you can use it. 2B indication MRA, you could do. 2B, if you don't have that ARNI, patient cannot afford it, you can try valsartan or ARB I'm talking about. So this is the current treatment options we have. Unfortunately, not as robust that we see in heart failure with reduced ejection fraction. Okay. But one thing that we need to look into that, when you treat heart failure patients with preserved ejection fraction, look at the comorbidities. You can significantly improve their outcome and quality of life if you focus on the individual disease comorbid that exists with these patients, like atrial fibrillation. Be aggressive on that, okay? If you can rhythm control, it's better option for them, okay? If cannot, just do rate control, okay? Definitely they need to be on anticoagulation because a lot of people have a stroke and die from that. So hypertension, you need to really control their blood pressure well, okay? If there's underlying coronary artery disease, you need to look for that, treat that. Diabetes, you need to look for that, treat that. And this type of patients, SGLT2 inhibitors like dapagliflozin or empagliflozin would be first-line therapy, okay? But you can do also GLP-1 antagonist, okay? Like you can do semaglutide type medications. You can use that in that group, okay? Definitely, if they have kidney disease, then you can use, renin-angiotensin system inhibitors that we talked about, and SGLT2 inhibitors may slow progression of the disease. So you can use that. So look at that. And sleep apnea, you need to treat that because they can increase their quality of life. And obesity, definitely significantly, you need to focus on that weight loss. They improve hemodynamics, functional status, quality of life, restrict their calories, let them exercise, and if necessary, put them on semaglutide for weight loss That's also an option nowadays available. So these are the current treatment options that I could summarize in heart failure with preserved ejection fraction. So I'm going to stop here if you have any questions. Hello?
স্যার কারো যদি কোনো কোশ্চেন থাকে আপনারা হ্যান্ড রেজ করতে পারেন, আমরা অ্যালাউ করব, অথবা চ্যাট বক্সে লিখলেও হবে বা হ্যান্ড রেজ করলেও হবে। ওকে,
I know it's a difficult concept, but
ডক্টর নসীনকে আনমিউট করলাম। ডক্টর নসীন, প্লিজ।
Assalamu alaikum, sir. That
Walaikum
was
assalam.
an excellent presentation, especially the part, that diastolic dysfunction part. You cleared it up really well. Sir, would you say that this heart failure with preserved ejection fraction is a diagnosis of exclusion? Do we need to go through the whole algorithm, or can we quickly shift to the cardiac part so that I can find out which part, since I am a resident of cardiology, which patients belong to me or not? Is there any shortcut, or is it actually a diagnosis of exclusion? Thank you, sir.
You can say probably the later one. The reason is we need to make sure that we are not dealing with other causes of shortness of breath and lower extremity swelling, okay? Definitely if there's any anemia going on, if there's any pulmonary cause going on, if there's or there's a non-cardiac mimics we talked about, that's I focused on that, go step by step, because you need to be very definitive. Because reason is, if you miss that like cardiac mimic, like if you miss amyloidosis, right? And you put that HFpEF treatment, but you're not really treating specifically cardiac amyloidosis, because that's a treatment available. If they're transerythrin positive amyloidosis, very definitive treatment like tafamidis is available that has shown mortality and quality of life benefit and hospitalization, okay? So we don't want to miss that. As for example, like patient has hypertrophic cardiomyopathy, it's clinical diagnosis, but you don't want to miss that because treatment is totally different. If the patient has pericardial disease, right? The patient might go pericardiectomy or certain things, okay? You don't want to miss that. So I probably current approach from our experts, go step by step, because reason is once you diagnose that, you confirm that, then you don't want to go back, okay? Because if you don't exclude those, then always there'll be question that we're missing those diagnoses or not, okay? If the patient has, you probably already figured out looking at the labs whether the patient has anemia or not, whether the patient has ferritin level is too high, or the patient has hemochromatosis or not. But you need to go that step-by-step approach. The reason is that makes your algorithm correct, okay? So always try to have some step-by-step approach. That's the way we teach our fellows and residents so that they don't miss those things. Okay, I think I'd probably go step-by-step. It will not take too long. Basically, you might do pulmonary function test, and most of the things you can do by echocardiogram and by lab work. Okay, it's not going to take too long, because otherwise, if you don't do that and you're treating something that's not there, the patient is may not, because if the patient has amyloidosis, you're treating with like AGLT inhibitors and other things, the patient is not going to improve. Particularly if the patient has clear-cut evidence that if it's ATTR cardiomyopathy, like transerythrin, amyloidosis, then they're not going to improve that, right? So yeah, I'd probably go step-by-step approach that would be better. Okay, next question.
স্ক্রিন শেয়ার করে আসেন, একটু ঢাকা ট্রিবিউনের নিউজ বেগুলো একটু অফ করে হবে।
All right, next.
লাস্ট কোশ্চেন আমি নিচ্ছি ডক্টর সুমন দাস। ডক্টর সুমন দাস, আপনি কোশ্চেন করতে পারেন। হ্যাঁ।
Thank you, sir, for the excellent presentation regarding heart failure with preserved ejection fraction. My question is, sir, pathophysiologically, you have shown that pulmonary capillary waste pressure regarding the diagnosis of the heart failures. So, is it heart failure with preserved ejection fraction? Is it right-sided heart failure or left-sided heart failure? Yeah, there's a little confusion in my mind. Please explain, sir.
Sure.
Thank you.
Let me just try to clarify a few things here. As for example, if you get like pulmonary capillary wedge pressure like 16 or 18, okay, it is elevated, right? The question right now is left-sided heart failure or right-sided heart failure, right? If the patient has like normal ejection fraction, okay, we don't expect that the patient, we don't expect that the patient will have, elevated left atrial pressure would be high unless they have diastolic dysfunction that we already documented by echocardiogram. Echocardiogram will be very important here. If you see that ejection fraction is fine, you don't see other valvular disease like mitral regurgitation or severe aortic regurgitation that can mostly, or mitral stenosis that can cause back pressure and raise the pulmonary capillary pressure, right, waist pressure. If you exclude those, then you can think it's most likely probably a diastolic problem, elevated filling pressure, and most likely HFpEF. And HFpEF initially starts on the left side problem, the filling pressure, then gradually goes to the right side. Because you know that filling pressure goes to the left atrium, from the left atrium goes to the lungs, and goes secondary pulmonary hypertension. Ultimately, it goes to the pulmonary vasculature is involved, which is due to secondary pulmonary hypertension, ultimately gets to right heart failure. But if you see the patients already presenting with right heart failure, if it's true HFpEF, it's probably late stage or advanced stage. Yes, it has a connection to that. But initially, they will not present with right heart failure in the beginning. Beginning, they have short of breath, they're still compensating, but when they exercise, they get short of breath because the curve is very steep. With exercise, the filling pressure with the same level of volume, the pressure goes way up, like slope is very high. That causes back pressure to the lung, they get short of breath.
Thank you, sir. Thank you, sir.
আমি লাস্ট কোশ্চেন নিচ্ছে যে
Mhm.
স্যার হাউ লং উই শুড কন্টিনিউ ডায়াবেটিক আর হাবিবা তুমি ওই ফর্মটা দিয়ে দেবো আজকে যারা ক্লাসে ছিল
Diuretic is your mainstay of treatment, you know that, because their filling pressure is high. So you need to really decrease the pressure. You need to put them on fluid restriction, salt restriction, lifelong. Answer is lifelong. And ultimately, when it goes to later stage, even it might not work. Then you need to think about like hospice care or heart transplantation.
Sir, thank you very much for your true world-class presentation.